Good afternoon and welcome to our Neuroscience lecture series. During this interactive presentation, you will have the ability to ask questions via the chat box on your screen. Please post your questions directly to the moderator. This afternoon, I have the distinct pleasure of introducing Dr. Justin Sporrer. His presentation will be high-intensity focused ultrasound for treatment of tremor disorders. Dr. Sporrer is a board-certified neurosurgeon and director of functional neurosurgery at Miami Neuroscience Institute. Dr. Sporrer received his medical training at the University of Florida College of Medicine in Gainesville, Florida, where he also completed his internship and residency in neurosurgery. During his residency, he's received his numerous honors, including the Charles Chuck Chang Award in Neurological Excellence and the Resident Teacher Award. In addition, he served as a chief resident and was a clinical research fellow at the UF Center for Movement Disorders. Dr. Sporrer has a special interest in general neurosurgery and deep brain stimulation for movement disorders. He's a member of the American Association of Neurological Surgeons and the Congress of Neurological Surgeons. Dr. Sporrer has lectured and presented research findings at medical meetings and published widely in medical journals. Please, let's give a warm welcome to Dr. Sporrer. Thank you, Dr. Sporrer, for joining us today.
Thanks for having me. So are we ready to begin?
We are.
All right, so thank you to everybody that's watching, and I hope to make this an informative talk and that you get something out of it. And I also hope to make it nice and short for you, because in this era of Zoom meetings, we have all had these 1 and 2 hour meetings that are unbearable and everybody starts to lose attention. So today I want to talk to you about high frequency ultrasound for the treatment of essential tremor. It's a new technology for an old diagnosis, and it's very exciting. So again, there is a Japanese PowerPoint technique called pechakucha, where you only have 20 slides and 20 seconds each, which comes to a grand total of just a few minutes. We'll take a little bit more than that, but I really want to be able to convey these complex concepts in a simple way. And then if there are any questions or anything at the end, we'll be happy to answer them. So let's talk about ultrasound. I think we're all fairly familiar with the concept of ultrasound, particularly diagnostic ultrasound when looking at a baby in utero. It has existed both in diagnostic and therapeutic realms. And so when you think of the therapies, we know that at high frequency, these ultrasonic waves are able to actually increase energy of a tissue, which in effect increases the temperature. And at high temperature, we are able to actually kill or stop cells that we don't want to be active anymore. And in the past, even in the last few decades, they have been able to harness that energy to kill cells, for example, of a tumor in the abdomen or the liver or the uterus. And I'll tell you, part of the reason they were able to do that is because there's nothing really blocking ultrasound from entering your abdomen if the transducer or the tool that they're using is right over those organs. But we have a brain problem, or more accurately, it's a skull problem. Unlike the liver and the uterus and all these soft tissue organs in the abdomen, the brain is housed in this hard shell that is very difficult to get past. It's a barrier, and it's a barrier on purpose. That's how we were made or evolved, to protect the crown jewel of your body, which is the brain. And don't tell the cardiologists I said that, but I think the brain is the most important organ in the body. And so the big question was, how do we maintain that same level of energy, the amount of energy needed to cause an ablation, with very specific accuracy across this hard surface? Because we know that the skull can either absorb energy and lower the amount of energy, or it can refract it or change the direction, which would change its accuracy. I like to think of if you were talking to somebody who was in a pool and then they went underwater, well, that change from air to water changes the way that the sound waves are transmitted. A lot of those sound waves bounce off the surface and you don't hear it underwater. And for those waves that actually make it through the surface, it sounds muffled or different than it would hear in another medium, or how it would sound in another medium. And so the same concept exists when we're trying to introduce ultrasonic waves into a very specific part of the brain to cause an ablation. It's a fancy word for burning a few cells in the brain to achieve a goal. So the other brain problem was, even if we were able to introduce that energy, we want it to be so accurate so that we know exactly how much energy is being introduced and what the temperature is at any given point in the brain. And so how do we know how much energy we're delivering? What is the temperature inside the brain? Are we causing an ablation, which is actual damage to these abnormal cells? And is an effect taking place? And so with the ultrasound machine, it's just a matter of dialing in the amount of energy. The MRI is able to know the temperature at any given point deep inside your brain, which I think borders on science fiction. It's like taking a picture of your Thanksgiving turkey or your Christmas turkey and knowing exactly what the temperature is deep inside at any given point, because we know it doesn't happen evenly either. And when we're talking about making changes deep in the brain, we want to know exactly what's going on at every given point. And then we can just take that, those two things, the amount of energy, the temperature, and the amount of time that it's being delivered, to determine, is that enough to cause a permanent change to cook those little parts or not? And that's an ablation. And then of course the neurosurgeon can check for an effect by testing whatever symptom we're trying to treat. And in this case, the one application that we are best at using high frequency ultrasound is to treat tremor. So this technology is called MR guided focused ultrasound, but HIFU is easier to say. And so that's how we'll be referring it to it. And with the HIFU machine inside of an MRI machine, we're able to get a real-time heat map of exactly what's going on at the target, which is about the size of a pea, the vegetable, deep within the brain. So let's talk about essential tremor. It is the most common movement disorder in the brain. About 1% of the worldwide population will develop essential tremor, and 5% of adults over 60 years old. So that equates to millions and millions of people who have a tremor. And we know that for essential tremor, which is unlike Parkinson's disease, unlike tremor associated with stroke, unlike the physiologic tremor that we all have when we're nervous or something like that, essential tremor has basically one symptom: tremor when they go to do something, such as drink from a glass of water, writing their name, writing a check, eating, shaving, very simple activities which are made nearly impossible by this disease. We know that it is a problem with a specific circuit in the brain. And so gone are the days when we think, okay, well, this part of the brain controls this muscle, and this part of the brain controls emotions. It's not that simple. It's actually 5 different parts of the brain, or 10 or 20 different parts of the brain are constantly communicating in a circuit, a cycle of electrical activity to produce a smooth result. And that goes for every aspect of our brain function. So if, for example, somebody has schizophrenia, well, we know that they have changes in their behavior and emotions that can go up and down and up and down. It's not very smooth. It's an abnormal circuit or abnormal electrical activity in their brain. In the case of tremor, the circuit that allows us to constantly be modifying our activities has a problem in it. And so when you think of a simple task like touch your finger to your nose, well, a million calculations have happened between here and there, so that if I'm off by a millimeter, my brain can make a slight change and make sure that it's perfect. But if there's something wrong with that circuit, then those calculations are stumbling and the appearance of that movement can be jerky or tremulous. That's a tremor. One of the nodes or kind of train stops along the way of that tremor circuit is an area of the brain called the thalamus, which is about this big and it's deep inside the brain. The good thing about essential tremor is that it's got a very testable symptom. We're not talking about a mood disorder where we would have to take a long history to figure out whether there's been a benefit or not. We have just the tremor and we can say, touch your finger to your nose before the treatment, and we can say, touch your finger to your nose 5 minutes later and see if it's better. And if necessary, we can make adjustments in that targeting process to make sure that we're in the exact right location. Test drive. And so that's what I was just alluding to. The high frequency ultrasound allows us to deliver a lower amount of energy first, such that we are stunning those abnormal cells, but without making a permanent change yet. And so, we have had the ability in the past with some invasive type treatments to make this same ablation deep within the thalamus. But once you introduce that energy, that was it. It was permanent. And if you were in the right location, great. And if you were not in the right location, then that's a problem. They can have unintended side effects. In this case, with the high frequency ultrasound, we can introduce a small amount of energy first, such that the cells are turned off but not damaged. Have the patient come out of the machine and test them out. Is their tremor still there or is it gone? If it's gone, then we know we're in the right location and we feel confident to turn the energy up and make that change a permanent change for the rest of their lives. And if their tremor is still present or they're feeling a little bit of tingling in their face, well, that could mean that the target that we're aiming at is 2 millimeters away from where we want it to be. And it's very simple. We move the target, do it again, test it out, and then through that process, we're able to get the exact right location with the effect that we want with minimal or no side effects. So what are the advantages of this procedure? It's non-invasive. Pretty much every single person that I see for this procedure comes to me and says, yeah, I've heard of this thing called deep brain stimulation in the past, but I don't want brain surgery. I certainly don't want it awake, which is how it's done. And I don't want anything implanted in my brain, an electrode. Number one, they just don't like the idea of it, or they don't want to have to worry about that thing plus a battery for the rest of their lives. I will, as a side note, say that deep brain stimulation is a fantastic treatment for tremor and for other things like Parkinson's disease. It's much more effective. And so that's going to continue to be a part of my repertoire, and we're going to be able to offer it to patients for whom I think it will be the best treatment. But I certainly understand people not wanting open brain surgery or having anything implanted. I have to say that it doesn't sound very attractive to me either. And so it's non-invasive. There's no hardware to worry about. You sidestep all the risks that you associate with surgery, such as bleeding or infection, changes in blood pressure that might, cause cardiac event. The advantage of this particular technology over previous technologies is that we have that ability to take a test drive before we make any permanent changes. And then lastly, it's super effective. Patients have 1 minute, this terrible tremor. They're not able to shave their face. They're not able to pick up their granddaughter for fear of dropping. And the next minute, they look like you or me. And that's super rewarding and very satisfying as the surgeon. Definitely for the patient and their families, it makes such a difference. There are some drawbacks. We do have to shave the patient's head for the procedure. Apparently, little air bubbles attach to your hair and your hair follicles. And when you heat up air bubbles, what can happen is they create bigger air bubbles like steam. And so the head has to be shaved, and that allows for the ultrasound waves easier access into the brain. I would say it's not like a super easy alternative when you compare the day of the procedure to the day of the procedure, for example, for deep brain stimulation. The side effects that somebody can feel during the procedure, which are very temporary, a couple seconds, are the feeling of warmth in the skull, or even a sensation that you're doing a backflip when, of course, you're not. But I have found that if I warn the patient about those possibilities, when it happens, they're not concerned. They don't get anxious about it because they were expecting it. And the other drawback is that it's not modifiable. Once we've done it, if the patient's very happy with the results, then that's pretty typical. If they wish that something more was different, then it can't be modified after the fact. And then what can also happen is the area that we're aiming for is very, very small and interconnected and next to lots of other circuits within the brain, such as the circuits that control your balance or the circuits that control sensation to the face and hand. And so oftentimes what can happen is somebody will have problems with either one of those things, balance or sensation. But the good news is it's almost always temporary. Within a few days, it clears up, but the tremor and the loss of tremor remains. So here's just a couple final points that I want to emphasize, and I think we've kept it fairly short, but tremor is not just a part of normal aging. I've had lots of patients who come to see me for other reasons, brain tumors and spinal surgery, and they have a tremor, and I say, well, how long have you had that? And they say, well, 10 years, but I just thought I was getting older. That's not really true. It does happen to occur more often in older patients, but it's not normal. It can often be a sign of something that we have a name for, such as Parkinson's disease, such as essential tremor. And so it's definitely worth getting it worked up. Go see a neurologist, go see a neurosurgeon if you already know that you have essential tremor, because there are options out there, and some of them are quite easy and quite effective and dramatic. So I think you owe it to yourself to at least explore those options. Essential tremor, which is the disease that is best treated by high-frequency ultrasound, the first line of treatment is medication. And oftentimes it is a great treatment for several years, but as expected, the disease continues to progress, the tremor can get worse, and the medications become less and less effective. And so that's the time when a lot of people will explore other options. One of those options is high-frequency ultrasound. It's a new, safe, and very effective treatment of tremor. And I'm very excited about it. The patients that we've done so far are very excited about it, just because it's amazing to see somebody's life change in a few minutes, and then they can go on living their normal life. So that's my presentation, and thank you so much for having me.
Thank you very much, Dr. Sporrer. As usual, this is exciting times in neurosurgery when we bring new technologies to help those patients that are in desperate need of help, especially with those patients that have no idea if it is just an essential tremor or Parkinson. As a matter of fact, there is a question from Costa Rica, and it reads, does this treatment work for the Parkinson patient that is more stiff than those patients that are suffering from tremors? Can it be applied in patients that have had Parkinson's for years?
So that's an excellent question. The answer right now is that it's best for tremor. And so there's two parts to the answer. Number one is we are currently able to treat patients who have tremor-dominant Parkinson's disease. They don't really have some of the other hallmarks, the stiffness, the rigidity, the slow movements, the balance issues of many patients with Parkinson's disease. Some people only present, their only symptom is tremor. And so that actually has been shown to improve with high-frequency ultrasound. However, those other symptoms do not improve with what's called a thalamotomy, or an ablation at that one specific location that controls tremor. And so in those patients who have lots of the other symptoms, stiffness and rigidity, I really recommend other treatments. And if you're to the point where you're considering surgery, deep brain stimulation is the much better treatment for that. The second answer, though, is that there are plenty of scientists and neurosurgeons who are looking into causing that ablation at other locations in the brain that are involved with the circuitry that we know exists with Parkinson's disease, as well as other diseases, for example. Basically, you're looking for some abnormal circuit and then trying to identify one of the points along that circuit and disrupt it. And so that research is being done, and I would guess that in the future, there will be many more diseases that can be treated with this.
George Pasantes is wondering, what is the result in Cephalon tremor? I'm not familiar with the Cephalon tremor. Can you elaborate on that?
So I presume that that refers to a head and neck tremor. That's an excellent question, which I didn't include in my presentation. The effectiveness of all treatments, the deep brain stimulation, the high frequency ultrasound, tends to be much greater in tremor of the hand and arm. Tremor of the head and neck, for many reasons, is more complex and harder to treat. It's not impossible that it could get better, but for every surgery that I do with my patients, I give them kind of a certain level of confidence that I have that this procedure is going to help them. And so, sometimes I say, I'm almost positive this is going to help you. And other times I say, listen, we've kind of reached the end of all other treatments. I'm not sure whether this is going to work or not. And just so that we are on the same page in terms of expectations. So it's not impossible that somebody has a head and neck tremor that's helped by this, but it's a little bit more challenging to say with confidence that it's going to help. What the patients that are probably best are the ones that have both, head and neck and an arm tremor, because then at least I'm confident that we can treat the arm tremor. And if it happens to make the other tremor better too, then that's kind of icing on the cake.
There is a question here that is asking about if the HIFU is covered by insurance. And I said, well, I could probably answer that. Some instances, the insurance companies will opt to actually approve the treatment, and others will consider it perhaps experimental. So that is depending on the type of insurance that you might use.
Yes.
Is HIFU appropriate for tremors associated with MS?
Right now, probably not. Again, that is an area of investigation that is happening, but we do know that the tremors associated with multiple sclerosis oftentimes are, they are the result of an abnormal circuit in the brain, but it's a different circuit. And so those tests where somebody has made an ablation in that different circuit to see if they can get rid of the tremor have not reached the point where we can offer that right now.
Great. Hello, Dr. Sporrer. Thank you for the lecture. My question is HIFU widely used, or is it the last resort for these type of tremors?
Well, there's two questions. Is it widely used? I would say in a general sense, no, it's not widely used yet, just because it's a new technology. I do want to emphasize that the idea of creating an ablation deep within the brain to stop tremor, that's not a new idea. We've known that for many years. What's new is how we get there and accomplish that same goal, but without an invasive surgery. And so I don't want people to think that it's this experimental thing. We know those circuits pretty well. Mm-hmm. And then the second part of the question was?
Is widely used, or is it the last resort?
Yeah, so
that patients might have?
It depends on the patient, I guess. But I don't think that we should reserve some of these excellent treatments as a last resort when you've already lost 5-10 years of good quality of life, particularly for something that is fairly low risk. You might as well take care of it, when you can, and gain those extra years of good quality of life. And so just to kind of weave in, because, the movement disorders is a whole family of diseases. Parkinson's disease, for example, some people say, well, I'll even get other physicians referring to me, say, well, they've done this, this, and this, and now their Parkinson's is so bad that they want to get deep brain stimulation. Unfortunately, that's not a good candidate. The good candidate for deep brain stimulation is somebody who's still benefiting from medication, but is having to take it over and over again to achieve the same effect. And it goes for essential tremor too. Now, if somebody comes in with a very minor tremor and says, I'm still working as a surgeon, or I still go to the gym every day, or I like to paint and I'm doing fine with that, I say, listen, even though this procedure is low risk, the benefit is going to be minimal. And so I'm always doing that, comparing the benefit and the risk. And so even if it's low risk, if the benefit is low, there's really no reason to do that yet. We always have these procedures in our back pocket available for people where it gets to a point where it really is affecting the quality of life.
Would that recommendation be also for a neurosurgeon with a small tremor?
Well, we'll see.
I think you will carve that one out. Oh, great. Has a method, I like this one, has a method been tested on patients with Tourette's?
So that's a great question. I don't think that it has been tested on people with Tourette's yet, but I was lucky enough to do my neurosurgery training and my movement disorders training at University of Florida, which is a major research university with a really excellent movement disorders program. And so they were involved in some of the trials of deep brain stimulation for Tourette's syndrome. And so that was just super fascinating. I think the general public thinks that it's a fascinating disease, but it's one that's often misunderstood. And again, we know that it's an abnormal circuit, but it's one of those diseases where it would be a little bit difficult to know in real time whether it was helping or not. And so in the case of deep brain stimulation, patients would have the electrode in for months, and then you would do it like a survey of, all of their various symptoms, the impulse control or the coprolalia or the jerking movements or the tics and things like that. And then you would kind of average them all over together and say, yes, this treatment worked. So that would be harder to know in a 5-minute span whether or not that had improved. That being said, people with Tourette's often will say that they have these like urges to have a tic, and they can suppress it for a couple minutes, but then the urge just gets greater and greater to the point where they have to do this or touch something or do something. And so one of the ways you could test it is to ask, how are your urges right now? Do you feel the need to do that or not? And so my vision would be to bring this technology to that whole family of diseases, and test it out. And so that research is being done right now. It's not being treated right now, not FDA approved, not insurance approved yet, but those experiments are being done around the world.
If a patient, an international patient, is actually interested on being evaluated by you, because of the pandemic, now we're using a lot of telehealth. What would be the types of records that you would require in order for you to at least have an educated idea of what you would recommend for a patient?
Well, I think that it's pretty simple, actually. What I would want is at least a primary care physician, or a preferable would be a neurologist note, because from a doctor's perspective, they're going to present the history of their tremor in a very specific way that doctors communicate with one another. How long has it been there, and when does it come on? What makes it better? What makes it worse? But that's a pretty simple thing to obtain. And then the second thing is the physical exam, and the history that I would obtain as the neurosurgeon is actually quite simple and straightforward. Unlike a lot of the other diseases, even a lot of the other movement disorders, you would want to have a very long history to discuss something like Parkinson's disease or Tourette's or something like that. But for essential tremor, I ask a few basic questions. Do you have a tremor when you go to do something, such as drink a glass of water, write with a pencil, things like that. Do you have any family history of tremor? Because many people with essential tremor have a parent that had a tremor or other family member. And number three, does a glass of wine make it better? Because if it does, that is very typical of essential tremor, the type of tremor that is best treated by this technology. And we can do all of that via a video conference. None of that requires, an in-person
visit with you. And eventually, obviously, if you consider the patient that needs to come for treatment, then
right.
You can determine that at a later time. Is there any type of, have you seen any type of recurrence of other foci within the brain that will require a reablation or resubmit the patient to the treatment?
So the field is changing, but yes, it is possible to get this procedure more than once. There are reports of people who have a great result, but 5 or more years later start to have tremor again in the same location on the same side. And so there's been reports of people getting it a second time. Right now, it's not approved for both sides because if we affect, for example, the balance fibers, which are nearby to the tremor fibers of the brain, for whatever reason, your brain's got a backup system. And so you can still maintain your balance if only one side is has a little bit of inflammation or swelling. But if you treat both sides at the same time, then that can, have a more disabling effect. And so that's something to keep in mind, again, when choosing which type of treatment you might be interested in. If it's a deal breaker that you have to have both sides treated, then this is not the treatment. Something like deep brain stimulation, however, would be an option.
Great. Is there a cutoff age for this type of procedure? Would a patient that is 80 in good health will qualify for the procedure?
Perfect candidate, because there's really all the things that we worry about as surgeons when you start getting into 80, 90 years old are things like, heart health, their ability to tolerate anesthesia, their ability to tolerate post-operative pain medications even. The risk of infection is greater. And so we avoid all of those things with the high-frequency ultrasound. It's really a great treatment for somebody who is not otherwise an operative candidate. And so, no, there really is no age cutoff. The thing is, somebody's got to be able to lay flat in that MRI machine for a few hours. Now, their arms and legs are free. They can scratch their nose or whatever they need to do. But in rare instances, somebody has difficulty breathing. It's hard for them to lay flat. But that would be the main limitation, in my opinion.
Fantastic. Well, Dr. Sporrer, I don't know where you learned that Japanese method of actually delivering a concise and precise type of information to the team, but this has been brilliant. Thank you so very much. We got you for those 30 minutes as promised, and I want to make sure I thank you once again on behalf of Baptist Health International for accepting our invitation, and to all of you for participating today, for your great questions, especially to our friends in Russia that joined us today. If you have any additional questions for Dr. Sporrer, please feel free to email it to us at internationalbaptisthealth.net. We look forward to seeing you in our next neurosurgical lecture series, which is scheduled for April 21st, 2021. In the meanwhile, please stay safe, get vaccinated when you can, and we'll see you soon. Thank you, Dr. Sporrer.
Thank you.